about classification, diagnosis, and assessment. So we're going to talk about how we classify. We're going to talk about the DSM-5, actually, is what we're going to talk about. And how things have changed over the last, since 52. 52, and this is 18, so that's 48. 48 and 18 is what? 50, 60, 66 years? The last 66 years, that's what we're going to talk about. How things have changed over the last 66 years. Once upon a time, there was a young lady by the name of Angela Savanti. She was 22 years old and she lived with her mother. And that's okay, you can live with your mother. There's nothing wrong with that, as long as you want to live with your mother. Angela and Jerry broke up 2 months ago. She became troubled by a deep unhappiness and frequent crying spells. She found it hard to concentrate on her job. She had difficulty falling asleep at night. She had a poor appetite. So we got all these negative things happening with her. She and Jerry broke up. She felt unhappy. She started crying all the time. She couldn't concentrate, and she had difficulty falling asleep at night. Does anybody else have insomnia besides Angela? No? There we go, we got one. She wasn't eating very well. Nothing worse than not eating very well, especially if you're hungry. I was so hungry last night. So I finally, yeah. No, I didn't. I ate potato chips. Don't be silly. I'm not going to eat. I know. What's better? Angela decided to see a counselor. She was referred to Millard Martine at the local counseling center. Millard tried to find out as much as he could about Angela. He sought to accumulate idiographic or individual information concerning his client. Idio, of course, means individual, and graph means picture. So he was creating an individual picture of Angela. We don't want to think that it's somebody else or whatever. Millard discovered that while Angela hadn't ever been depressed this badly before, she had periodically suffered from the blues. The blues. Another name for the blues is dysthymia. But we'll call it the blues, just between us. He diagnosed her with situational clinical depression from the trauma of her breakup and treated her with weekly counseling and maintenance Prozac for her periodic depression. Okay, so he's got a plan, right? He looked at her, figured out what was going on. She'd been kind of depressed, a little bit, dysthymia, it's nothing really serious. Nothing really serious going on. So he decided that he would counsel her and he would give her a maintenance level of Prozac. Increase her serotonin level, maybe. Gaining insight from her counseling, Angela discovered that part of her problem stemmed from her desire to study law and living with her mother. Now, I'm not saying anything negative about mothers, but sometimes people don't want to live with them for the rest of their lives. It happens. I certainly didn't want my kids to live with me for the rest of their lives, but I'm not a mother, right? Anyway, okay, so the good news is she moved out of her mother's house, and now her mother's having a grand old time at the casino and dancing. And of course, Angela is now in law school in Denver, at the University of Denver, which turns out to be a Catholic school. I didn't realize that. Anyway, and she no longer needs her medication. She still gets the blues from time to time, but that she doesn't need to really medicate herself. So we fixed her. We fixed her. We fixed her by getting her mother to kick her out of the house. She didn't actually do that, but for her doing what she wanted to do. And that's all we needed to do was to convince her that she needed to do something else. In order for us to figure out what was going on with Angela, we had to diagnose her. Diagnosis is Greek for discrimination. We're discriminating against this person and that person. This person has a problem, that person doesn't. So we can compare normal to abnormal. And in her case, unhappiness is not a normal thing. Not eating was not a normal thing. Not sleeping was not a normal thing. Okay, so we can identify all these things that are not normal, especially not normal as far as Angela was concerned. And this is what we have to do in order to determine if we need to treat somebody or how we need to treat them. After the therapist has gathered an accurate understanding of the client, constructed a clinical picture of what they're looking at, they will name the client's problem, and that's what diagnosis is all about. Now, there's a lot of psychologists out there that do not believe in diagnosing. They do not believe in attaching labels to people. Most of these individuals are not clinical psychologists. If you're a clinical psychologist, in order to get paid, you better figure out what's wrong with this individual, and you better find out what the ICD-9 code is, or ICD-10 code is now, I guess, and you better give them a code. Otherwise, the insurance company's not going to pay you. So unfortunately, we have to diagnose people in order to treat them. Well, that's not unfortunate, is it? We have to. Why would we treat somebody if they didn't have a problem? Right? I hope. Oh my God. What if we're treating people that we don't need to treat? So we need to determine if there's a problem. This is now done so that the therapist can treat the client and receive appropriate compensation from the insurance company. This is done by comparing the client's symptoms to symptoms of already established problems. And we do this by reading the DCM-5. It used to be the DCM-4-TR. Before that it was a DCM-4. Before that it was a DCM-3-R. And then it was before that it was DCM. Anyway, I started in psychology in 1975. And in 1975 we were reading the DCM-2. Everything has changed since the DCM-2. Everything has changed since the DCM-2. Okay, now we use the DCM-5. Every time a new DCM comes out, people start complaining about some of the stuff that's in it. A lot of people start complaining about all the stuff that's in it. And we're still complaining about the stuff in the DCM-5. It looks like we're going to get a revision one of these days. They're already accumulating revisions for the DCM-5-TR, I guess. I don't know. Probably it'll be TR. Anyway, we'll see what happens. Classification is part of a process that leads to a fundamental understanding of basic principles rather than just labeling a process. We have to classify what we're doing. We need to do it in a select manner. We can't just come up with something out of thin air. We need to use classification. The classification system for abnormal behavior has been based in large part on the manner of classification for physical disease. The reason we have the DSM-5, the DSM-5 is actually not written by psychologists. It's written by psychiatrists. Most psychiatrists are doctors. They're medical doctors who have a degree in psychiatry. How about that? So we have this huge number of people in the United States that are psychologists, and they don't have a book. But we have this relatively small number of people that are psychiatrists, and they're the ones that have developed this system of identifying what the problem is. As curious as that is. Okay. So since they're medical doctors, they refer to all of these things as physical diseases, or they look at these things as if they were physical diseases. So for that reason, if you look at the DSM-5, you're going, wait a minute, I'm a psychologist, I don't talk about this and this and this. But the reality is, of course, they're doctors, and they do. So when they look at a disease, depression, schizophrenia, it looks like they're talking about a physical disease. But we still use the DSM-5. It's okay. Don't worry about it. Well, you can worry about it if you like. Come up with your own, I don't know, it's like APA. They're the APA as well. The APA stands for American Psychological Association. It also stands for the American Psychiatric Association. I know, it's the same initials, and you have to know who you're talking to as to whether you're talking to a doctor or you're talking to a doctor. Whether you're talking to an MD or you're talking to a PhD, I guess. Okay, I know this gets very confusing. A major aim in the development of a classificatory system is to discover to what extent there are distinctive patterns of abnormal behaviors with their own causative histories. So what we do when we look at these things, these problems, we know that somebody has a personality problem. We know that this lady, she fixates on men and then she tries to bring them toward her. She tries to seduce them, and once she does, then she pushes them away. Well, that's not normal. That's not good. This is not going to end up well, is it? No, she's going to continue to have these really strange relationships with all of these guys that she pursues, and she pursues them until they like her, and then she suddenly pushes them away. And then sometimes they come back because they liked being pursued. So as long as they act like they don't like her, she likes them. But as soon as they act like they like her, then she rejects them. Do you get the picture? Okay. Now this is fairly toxic, if you can imagine. So what are we going to do with this lady? Or this guy? I mean, there are guys that have the same problem. What are we going to do with them? Well, first of all, we need to figure out what the hell's going on with this lady, right? And the classification we use for this individual is borderline personality disorder. She's a push me, pull me person. As soon as the person starts liking her, she rejects them. And now all of a sudden she's got either that relationship will break down and she has to start a new one, or this relationship is going to get toxic really fast. The guy's going to start abusing her because that's what she reacts to. Oh my God, this is terrible. Everything is upside down and backwards. I mean, people are supposed to love each other, right? And be nice to each other. But here we have a situation where she can't stand it. The nicer he is to her, then the meaner she is to him. Wow. I know. Wow, this is so upside down and backwards. So we need to classify this, right? We need to give it a classification. And the classification that we give to this situation is borderline personality disorder. Now, what kind of a history could this lady possibly have where she doesn't understand what's going on? What could possibly have happened in her childhood that would make her this way?
Rejection.
By whom?
Her father.
Her father. Okay. So we've got a rejecting father. And the more he rejects her, the harder she tries to get him to love her. And if it never happens, all of a sudden we've got a situation on our hands, don't we? We've got a lady that thinks that this is love. Wow. What about the case of an individual that's in an alcoholic home, where mom and dad are both drinkers? When are they going to love you? When they're not drunk, probably. Potentially when they're not drunk. I know. So you never know. You just never know when you're going to be loved. I know. Okay, so sometimes we have causative histories. And we can find out what their home life was when they were children, and we can determine what their potential problem is today. Does it work? Yeah, it really does. This is really kind of exciting. Or not exciting. The American Psychiatric Association, the APA, set up a model called the Diagnostic Statistical Manual of Mental Disorders, the DSM-1. Actually, it wasn't called the DSM-1 until after we had two of them. It was called the DSM. And we thought, well, this is the only one we'll ever need. Back in 1952 when they first published it. And then we realized it was crap. And we needed another one. We need a new one, okay? So then we started putting together another book. And that was the DSM-2. And as you can see, it took 16 years to put this thing together, to realize, well, actually they realized fairly quickly that they couldn't use it as a diagnostic manual very well. It really didn't fit. So they needed a new one. And finally in 1968 they came up with a new one. Yes, sir?
Can I ask you a question about the DSM-2?
Sure.
1 or 1
Yeah.
to 5?
Yeah.
Do you know when they added post-traumatic stress disorder?
Yes. In 3.
In 3?
Yeah. Or was it 4? I think it was 3. I'm pretty sure it was 3. Yeah. So we have to figure out that this is a problem first. We've always known that that was a problem. We had shell shock in World War I, we had combat fatigue in World War II, and then all of a sudden in Vietnam we started seeing similar symptoms, but it was different because the war was different. So we were seeing different things. So finally, after Vietnam, we decided that we would make this a mental disorder, or we would identify it as a mental disorder that these individuals would suffer from for an extended length of time. The idea after World War I was that these individuals would eventually get over it, and people kept telling them, well, you're just going to get over it. You're going to get over it. And they either died or they did, they got over it. Same thing happened in World War II. Of course, we won both those wars, right? But after Vietnam, we didn't really win that war. It was, and people weren't I mean, the soldiers coming back weren't all that happy about what was going on. So because of that, of course, now we have identified it as a problem.
I started reading, trying to read on PTSD
Right.
back in 2008, 2009. And the only literature I could find, only published books were about rape victims.
Right.
And it seemed like a lot of the stuff for combat fatigue was kind of like a lot more recent stuff.
Right.
And the VA didn't start categorizing people with that until like the 80s.
Right.
So do you think like a lot of these issues that we're talking about, like daddy issues, are PTSD issues for children that manifest in stress later in life?
Exactly. And now that we have a diagnosis, now that we have a categorization for it, now we can identify from the past and in the current situation. Before, if somebody had been raped, what happened? What do we call it? We call it anxiety. We had no diagnosis for it, but now we can call it PTSD. Now we know what it is. Now we've done a better job of categorizing it. So these things are coming up. Actually, this is changing all the time, and we don't know what's going to happen in the future. I was reading an article today from the New York Times. It was talking about children watching pornography, viewing pornography, because you can find it anywhere. It's on people's phones. It's on computers, and you know, this is maybe potentially a problem in the future. We've never seen anything like this before. So what's it going to do? What's it going to do? We don't know. We have no idea, because this kid is still a kid. When they grow up, are they going to think that that's normal? That's normal sexual behavior? And that's the question that they asked in the article. So, you know, in maybe 20 years, maybe 15 years, we're going to see a problem coming out of this mass pornography that people have, or children have access to. So we don't know.
So technology is changing and affecting the psychology as well.
Everything.
Or the culture, I guess. Huh?
Exactly, and we need to understand that. I mean, the DSM-5 is no absolute. We already know it's crap. We already know that. We already know that we're missing things, that we haven't identified things. One of the things that they identified in the DSM-5 that they had never identified before was computer addiction. They never identified computer addiction before, but now we know that it's a problem. So we don't know what's going to happen in the future. We don't know what's going to come out of Iraq and Afghanistan. Iraq and Afghanistan are the two longest wars we've ever fought, and we fought them in the desert. So we've never fought a war in the desert before, so we have no idea what's going to come out of it. We had fought World War II. Half of World War II was in the South Pacific, which is jungle, and Vietnam was in the jungle. So, you know, we had an idea of what was happening then, but we don't know what we're going to see in the future.
So the culture is always changing with technology.
Right.
And the DSM is playing catch up.
Right.
Then that means the psychologists are always a step behind the DSM, which is a step behind culture.
Exactly.
So how do you ever have troubles where psychologists have trouble with the DSM, or?
Oh yeah, sure.
Does it lead to a lot of misdiagnosing or mistreatment?
It does. Well, we have to diagnose what's there. We can't diagnose somebody with a problem that isn't recognized. So if somebody has a new pornography addiction of some ilk or something, I don't even know what it's going to be called. We have that shooter in, and I was talking about this last semester, we have that shooter in Las Vegas. Obviously there's something wrong, and you don't just start pumping away on 30,000 people in a concert. You know, that's just not normal. So, but nobody had a diagnosis. We still don't have a diagnosis for it. Pathological reclusiveness. you know, he was a recluse. We know that he was a recluse. But how do we identify this as something negative? How do we diagnose it as an abnormality? We know it's abnormal, but we have no diagnosis.
Another question then about this DSM-5.
Right.
If it's always playing catch-up.
Correct.
And then you bring up the point about the shooter in Las Vegas, right?
Right.
He had a lot of activity that they look back on now.
Right.
And that was suspicious, but it didn't break the law.
Right.
So he didn't get put on a watch list
Exactly.
or anything like that. What about like pathological liars? Is that a DSM-5? Because if they're not breaking any laws.
It's under several different diagnoses. It all depends on what's overarching. We don't just have a diagnosis of pathological liar. It's part of borderline. They're pathological liars. People with antisocial personality disorder, they are pathological liars. So it's not specific for pathological liars. Yeah, we would diagnose them with something else, probably antisocial personality disorder.
And then another question into that, like I know that postpartum has gotten more and more attention lately as well.
Postpartum depression?
Yeah.
Or psychosis?
Yeah. How does that affect a person? Like how far down the road does that affect a person?
In England, they allow a woman to do something negative to her child within the first year and a half. So as far as the Brits are concerned, they recognize postpartum depression as potentially lasting for as long as a year and a half. So if a woman kills her child and the child is 6 months old, then they don't prosecute her for first-degree murder. In England, in the United States, who knows what's going on? Well, we had the lady that drowned all of her babies, and her daughter was 6 months old. And initially we convicted her of murder, 5 counts of murder, but then they said that she was.
Ask you another question about the DSM-5?
Sure.
Or 125? When did temporary insanity become?
Temporary insanity is not in any of the DSMs. It's a law. It's a legal term.
Okay.
Yeah. So we can't get the two of them mixed up. One of them is a diagnosable thing. For example, a psychiatrist or a psychologist could not diagnose somebody with temporary insanity. He'd have to call it something else because it's not in any of the DSMs. But it's a legal term. So yeah, sometimes we have to be really, really careful. So this is really kind of fascinating, isn't it? Like, yes, we are playing catch-up. I'm glad you mentioned that. We're always playing catch-up, and we will always be playing catch-up as far as that's concerned. So what we need to do as psychologists is we need to be looking to our client population and determining if there's something new out there that we need to start talking about. Because if we can find something, then we need to tell somebody else about it. And what will probably happen, and of course this happens with any psychologist, you can't put any 2 psychologists in a room without getting an argument. Try it sometimes. So I don't teach with Sarah, she doesn't teach with me, or Dr. Wolf, or anybody else. You can't, it just doesn't happen. Because we don't agree on anything, hardly anything.
You're talking about psychologists not agreeing on things.
Right.
What are the different main groups of thought when it comes to psychology?
Oh, she would tell you one thing and I'll tell you something else. It all depends on where you go to school and what their emphasis is.
Is it in theory or is it in treatment or is it?
It's mostly in theory. It really doesn't have that much to do with treatment. If I'm a Freudian, I follow Freud's concepts of psychosexual problems in the past causing problems in the future. And there are a lot of people that won't teach Freud at all. They won't even talk about Freud. The cognitivists don't like Freud because he never did any research. Well, he couldn't do any research. It was 100 years ago, 150 years ago. So yeah, it's really kind of fascinating. This is a wide open field. So when we're teaching you about psychology, we're talking about Western psychology, but you guys are thinking in concepts of tribal psychology, of Navajo psychology, of the psychology of the Dene. And the reality is that is a very real categorization, because people's way of thinking can be potentially different. And I can't teach you that. I can't teach you that at all, because I don't know about it. But I can tell you about what Western people are thinking, and you guys are the ones that need to write your own textbooks about the psychology of this of your individual group. It works that way everywhere. The Brits have their own psychology. The Germans have their own psychology. You know, and this just happened to start out in the Western world. But you guys have to write your own stuff.
You mentioned tribalism a couple classes back.
Yeah. Yeah. Who was I telling? Oh, Johnny and I were talking about that. Okay.
But I was just thinking about it. I kind of didn't agree with you when you first said it, but I've been thinking about it over the last 2 weeks, and you mentioned it. I think there's a lot of subcultures within the main cultures,
Exactly.
and then microcultures, and I think that's the same thing as tribalism, isn't it? Everybody identifying together and then
Right.
safety.
Yeah. The point I was trying to make, and I could see that there were a lot of people that didn't really agree with what I was saying. But the point I was trying to make was that American Indians and the indigenous peoples of the Americas, you guys were as separated as European countries, in essence. I mean, you all called yourselves the people. And so the Sioux or whoever those people are up there, they separated themselves from everybody else by saying, we're the center of the universe. You guys say exactly the same thing. We're the center of the universe, and everybody else is on the periphery. And that's okay. I mean, that's fine. But you have to recognize the fact that you don't really accept people from the outside. They're still outsiders. And that's primarily what happens with what has happened in the United States with the dominant culture and with the minorities. You know, they're on the periphery. They're on the outskirts. They don't think the same way as everybody else. And of course, the same thing was going on before Europeans got here. You guys were separating yourselves from each other. And that's okay.
It made sense to me when I was watching the news. I was flipping between CNN and Fox.
Mm-hmm. Oh my God.
And then I was just, you notice the two wide narratives,
Exactly.
both sides push. And but we're all Americans, right?
Right, yeah.
It clicked what you said, it makes sense.
And the different tribes are the same way. I mean, you guys never talk about the Hopi, you never talk about the Apache. Who else lives in this area? The Yavapai, the Utes, exactly. You never talk about those things. But they're out there somewhere. You know, they're over in Farmington. I don't know. I've only been in Farmington twice. I don't know who was there. The Ikaria Apache are right on the other side of Farmington, so I'm sure they're out there somewhere. Anyway, yeah, that's the point I was trying to make. And thank you for mentioning that. Yeah, I could tell that nobody would agree with what I said. But, the more you think about it, the more you realize, yeah, geez, we only talk about us. We don't talk about them, whoever them may happen to be. And of course, I'm a them as well, and I recognize that as well. Okay, so we're talking about the DSMs. The funny thing is, it's not that funny. In 1952, they thought they wrote the book, and of course, it didn't turn out to be the book because in 1968, they came out with the book again. And this time, they had increased the number of mental disorders by 50%. They had increased it by twice as many. Why? Had mental illness had suddenly doubled and all these strange diseases had come up? No, they had been out there forever. They hadn't identified it up to this point. That was the problem. So there are problems out there that we don't see now that are not in the DSM-5. And one of them may have to do with pornography, because nobody wants to talk about naked people. Do they? They don't want to talk about it, but the reality is that it's affecting the people today, unfortunately. It's affecting children. It's affecting people become addicted to pornography. They look at pornography all the time, as odd as that may seem. Okay. So in the future, we're going to have to figure out what's out there. And as psychologists, we're going to have to be open to whatever is happening. because we can't close our eyes just because somebody uses the F word, you know. Okay, I'm sorry, you use the F word. You're going to have to leave my office. I don't want to talk to you anymore. I apologize. You know, okay. If you've ever talked to somebody with PTSD, combat PTSD, guess what every other word is? Okay. Okay. You know, you're constantly going, what, please? No. I know. I was talking to somebody the other day and he was having problems, and he was a combat veteran. My golly, I had no idea. You know, I haven't heard anybody talk like that since I was in combat, so it was really kind of interesting. There were concerns about accuracy and consistency with which the DSM-2 labels could be given. Agreement among clinicians on the use of a label often was no better than chance. And this is a problem. So if somebody, and this was a problem in Mississippi. I used to live in Mississippi. They had two mental hospitals. One was for black people and one was for white people. If you went to the white person's hospital, then they diagnosed you with bipolar disorder. If you had the same problem and went to the black person's hospital, they diagnosed you with schizophrenia. Now I know this is kind of tough because we treat the two differently. We give them different medications. So if you've got schizophrenia and you go to the white person's hospital, they're not going to diagnose you with schizophrenia because that's a black person's disease. That's a mental illness. So they're going to treat you as if you had bipolar disorder. Guess what's going to happen next? Well, you've got schizophrenia and they're treating you with lithium. Well, lithium's not going to do anything for your schizophrenia. So this was a really strange and serious problem. You were not getting the proper diagnosis just because you were the wrong race. Well, that's the way it was in Mississippi, but of course in New York City it was a little bit different. If you went to one hospital, the guy specialized in schizophrenia, so he diagnosed you with schizophrenia, you didn't react to the medication, so then he sent you to another hospital to be diagnosed. Now maybe at that hospital there was a doctor that actually specialized in bipolar disorder. Now we're okay because we're treating you with the right medication. And this is a problem. This is a real serious problem. Here's Chris and I, and we're diagnosing the same person, and I'm going, damn it, that person's he's depressed. And you're going, no, it's anxiety. He's suffering from anxiety problems. And so the two of us, of course, we're seeing the same patient, but maybe when the patient talks to him, they talk to him about one thing, and when they talk to me about something totally different. So he sees the patient as having anxiety issues, panic attacks, and I see the same individual as being depressed. So how are we going to treat the person? Well, he's going to treat them for anxiety, and I'm going to treat them for depression. But of course, you can only have one doctor. I know this isn't going to work at all. So this was a really serious problem, a really serious problem. The other problem is when Chris listens to this guy's story, he listens to one thing, and when I listen to his story, I hear something totally different, even though it's exactly the same story. I focus on one thing, and he focuses on something totally different. So this is a problem with psychologists and psychiatrists, with clinicians. And we started noticing this with the DSM-2. These are not absolutes. We can talk about the criteria all that we want, but the reality is that Chris and I are having problems because we focus on two different things. Unlike medical diagnoses, psychiatric labels were maintained by consensus alone. So we kept all of these really strange and odd mental illnesses that maybe didn't exist anymore. I've got I have my first abnormal psychology book downstairs. It was printed in 1972. You would not recognize it. There's hardly anything in there that is in your textbook. Despite the fact that it's an abnormal psychology book, and when I was going through my to get my master's degree, this is the book I studied from. And it doesn't look anything like your textbook. The stuff in your textbook is not in that textbook, as bizarre as that is. It doesn't talk about personality disorders. Really? Were there no personality disorders in 1972? Of course there were. but they called it something totally different. It's really bizarre. A good example is homosexuality. Homosexuality was considered a mental illness until 1968. Well, after 1968, 1970 something. 1980 was when it was diagnosed as not a mental disorder among clinicians. Before 1980, it was still in the DSM-2 as a mental illness. How bizarre is that? Is homosexuality a mental illness? Well, no, not now, but it was in 1980. So you could be diagnosed and put in an asylum, not asylum, you could be put in a hospital, a mental hospital, for homosexuality. As bizarre as that seems. I know, as odd as anybody can think of. And evidently, if you look at Sigmund Freud, when Freud started dealing with people's problems, with people's mental illnesses, the one mental illness that he couldn't treat, that he was an abysmal failure at treating, was homosexuality. He tried to treat it, this way, tried to treat it that way, tried to give them testosterone, he tried to give them cocaine to change the way that they reacted, and the reality was it didn't change anything. He was very unsuccessful. He could treat anything else. He treated bipolar disorder, he treated schizophrenia, he treated all the hysterias, which we don't have anymore, but he couldn't treat homosexuality. It's the one thing he couldn't treat. The DSM-3 published in 1980 represented a marked improvement from the two earlier systems. Criteria became more objective and behavioral. The largest structural change involved the introduction of 5 separate dimensions or axes on which the individuals could be evaluated in order to give a more complete clinical picture of a person. And this was referred to as the multi-axial diagnosis. Okay, I started in psychology in 1975. We didn't come out with this until 1980. So I've been teaching this for the last 25 years. 25 years, okay, 25 years. I didn't start teaching right away. And I had to start teaching the axes even though I wasn't taught the axes when I was going through an abnormal psychology class. Okay, now this makes a lot of sense. Anytime you see somebody, you need to identify whether they have a clinical disorder or other condition that may be a focus of clinical attention. So you need to give them that. You need to use this classification. It's very logical. So we need to decide if they are have one of those kinds of problems. We also need to identify whether they have an intellectual deficit. At the time, of course, they referred to it as mental retardation. We don't do that anymore. We also needed to decide whether they had a personality disorder. Suddenly, in the DSM-3, they started putting in personality disorders. In the DSM-2, there were no personality disorders, and that's why my textbook from 1972 has no personality disorders in it, as bizarre as that may seem. But we need to identify these things. So we need to decide whether they're depressed. We need to decide whether they have borderline personality disorder. We need to decide whether they have an intellectual deficit. This is really important. Whether they have an intellectual deficit or not. Because if they do, that's going to change everything. If they have an IQ that's in the 50 range, then that's going to change the way we treat them. So that's very, very logical. There's also a lot of medical conditions that can cause problems that look like mental illness. So we need to talk about what their medical problems are. This is to give them a good diagnosis, an accurate diagnosis. And in health psychology, we've already talked about being hypothyroid, and it makes you act lethargic and depressed. Hyperthyroid makes you act like you are manic. So here's a medical condition that potentially can cause somebody to look like they have a mental illness. Hypoglycemia. They have erratic behavior. Well, that looks like a mental illness. So if we treat them for their mental illness, despite the fact that their real problem is the fact that their blood sugar is too low, well, all of a sudden, well, we're not getting any reaction from them, are we? So we need to know these things. We need to know their medical situation. Their psychosocial and environmental problems. Are they poor? Are they a combat veteran? does this potentially have something to do with something that happened to them when they were in combat? Or did they have PTSD? Yes, sir.
Any of these 5 axes,
Mhm.
does that include asking if you have mental disorders in your family? Or is that comes
Historical aspect? No, it doesn't. That's part of the history that you would gather otherwise. So when you are talking about, see, that could prejudice the clinician against the individual. If they have schizophrenia in their family, they're going, oh, he must, I have to look for schizophrenia. Well, you know, he's blinded to any other problems
okay.
with the individual.
So they don't. So they don't.
No, so they don't talk about your history. Not here, but of course they're going to take a complete history when they the initial interview. They'll take a complete history. Really kind of fascinating stuff. Those of you who have had 291, if you've had 291, that's one of the things that we talked about was the history, the client's history. So it's really important as to what potentially might be a problem. But if we focus on it, unfortunately, sometimes that blinds the individual to what the real problem is. The last axis is really kind of interesting. It's the global assessment of functioning. So on a scale of 1 to 100, how functional is this individual? Can they function on their own? Can they be, or do they need to be hospitalized? And that's really what the number 5, axis 5 is all about. It's telling us how functional they are. And this is the one that everybody argues about. Because on a scale of 1 to 100, where are you? You know, I'm a 74. You know, this is like my IQ. This is really high. I'm a 99, man. Come on, man. No, he's only a 54. Let's put him in the hospital. We'll bring him in for counseling every 3 times a week because he's only a 65. Okay, let's do that, you know. All kinds of strange stuff happen. The multi-axial approach continued through the next 3 revisions of the DSM. The DSM-3R, revised, R stands for revised, was released in 1987. The DSM-4 was released in 1994. This is the one that I worked with more than any other DSM, the DSM-4TR. I have a copy of it. Where do I have a copy of it? I think it's in Iowa. But I have a copy of it. I didn't bring it here. I have a copy of the DSM-5 downstairs if anybody wants to see it. It's purple, and that's important. No, it's not.
How much did it cost?
I'm sorry?
How much did it cost?
I don't remember. $45 or something like that. I know. It's hardly anything. I know they almost gave it away. My other one cost like $12, my DSM-4TR, and it's like 200 more pages. You know, I got a bargain. Of course, that was a million years ago when I bought it. The DSM-4TR is silver. So just in case you wondered. Anyway, mine is. I don't know if they're all silver. Much was altered in the DSM-5, which came out in 2013. Actually, it came out in 2014. Didn't come out in 2013. It was first published in 2013, but they didn't allow it on the market until 2014, in May. Okay. They were still revising it, and they published it, and they were still thinking that they would revise it. There were people that were really upset about it. One of the things that they were upset about was Asperger syndrome. Asperger syndrome was no longer in there. Actually, I talk about it right here. Asperger syndrome was no longer in there. Instead of talking about Asperger's and autism, what they talked about was autism spectrum disorder. Yeah, autism spectrum disorder, which should be autistic, but they called it autism spectrum disorder. So it looked like, so if you've got autism, I mean, if a child is suffering from autism, that's a fairly severe diagnosis. In the old days, they called this person, they said that this person had autism. If somebody had symptoms of that were very similar to autism, but it wasn't as severe, they called it Asperger's syndrome. Okay. This person is totally functional in society, and this person potentially has a difficult time functioning in society. Okay. So when they changed it to autism spectrum disorder, now all of a sudden they threw all those people in the same diagnosis. And the people with Asperger's, that's, or their parents with that stuff. Okay. they didn't want their child identified with autism because they were afraid people would stigmatize them and think really negative things about them. So this is a really serious situation. And that's it was like 6 months. They didn't publish this because of the people that had children with Asperger syndrome. They were screaming, and they're still screaming. And for that reason, they'll probably come out and change something in the future. They'll probably take the less severe form of autism spectrum disorder, and they'll make it a new category. They'll make it something else, potentially. And this is really serious stuff. I know college professors with Asperger syndrome. And they're fairly functional. They're not very much fun, but they're fairly functional. I had a friend in college that had Asperger's. I keep telling my story about John. He could sit in the middle of a party with naked people and everybody drunk, and he could sit there and read a textbook. He was amazing. I know. He's a college professor today. He teaches English. The most boring professor you can possibly imagine. His voice never modulates. He just talks in a monotone all the time. But he's pretty. And since he's pretty, people take his class. It's just the most bizarre thing ever. Pisses me off. Man. He also... Did
you say he was pretty?
He's very handsome.
Oh, okay. I couldn't hear you on that side.
I'm sorry, he's a very attractive man.
Oh, okay.
He's not only an attractive man, but he had an affair with my wife. In college, I know.
Oh, that John.
Yeah, that John. Yeah, there you go. Okay. Now you know what I'm talking about. Okay, yeah. Bastard. But knowing John, he may not have realized what was going on. I mean, he was kind of, everything went over his head. I mean, women would throw themselves at him and he'd just miss it completely. It was just something going on with that guy. But he was very attractive. I didn't find him attractive, but my ex-wife, she found him very attractive. Don't write that down.
That's not going to be on the test.
It's not going to be on the test.
Research paper.
I would start crying if I put that on.
DSM-4.
Oh, man. Anyway, okay, so he had Asperger's syndrome. I'll be all right. Okay, there we go. The DSM-5 remains a categorical diagnostic system. However, it includes specific dimensional assessments to quantify degree of symptom severity or to measure personality traits. A level 1 assessment involves a survey of 12 or 13 symptom domains rated on a 5-point severity scale, and this is how we're rating people now. A more in-depth level 2 assessment involves additional checklists and rating scales that are more specific to the issue. So initially you use a level 1 assessment and you diagnose them, but then you have to do a level 2 assessment, which is more in-depth. So we have changed our diagnostic methods, as bizarre as that may seem. In order for a diagnosis to be reliable, different clinicians should come to the same diagnostic conclusion after independently examining the same patient. And this is known as diagnostic reliability. But like I told you, you can't find any 2 psychologists, besides Chris and I, of course. We're kind of on the same page. Well, not well enough. But we could be on the same page. But it's really difficult to find 2 psychologists that agree on anything. They may do different forms of therapy. And since they do, they have different ideas about how you're supposed to read a problem in a select individual. Their agreement on a diagnosis suggests that the label can be applied in a consistent way, and this is what we're hoping for. So all depression kind of looks alike. But we have depression with anxiety, so what are we going to do? I'm going to treat them for depression, and Chris wants to treat them for anxiety. Which is the more severe problem? Is it anxiety or is it depression? Well, Chris is going to think that it's anxiety that we need to deal with. If we can deal with the anxiety, the depression is going to go away. I think that if we deal with the depression, the anxiety is going to go away. Okay, so if we are diagnosing the same thing, but we have different ways of looking at it. Diagnostic reliability can be measured through a kappa statistic. As in correlations, kappa values of 1.0 indicate perfect agreement, and of course the probability that we get a perfect agreement is fairly remote. Looking at the DSM-3, a reliability estimate of 0.70 or higher was considered to indicate good agreement in the use of the diagnosis. So when we came up with all of these different problems, we started looking at, we did field studies, looking at whether these diagnoses were accurate or not. Were we getting a kappa value of above 0.70? That was the question. So sometimes they're fairly easy to read, but as we're going to see, nothing is perfect. Even if we're looking at exactly the same thing, we're only going to see even a kappa value of 0.70. That just means that 70% of the people looking at this client saw the same thing. That means 30% missed it. Wow, that's a lot of misdiagnoses if you think about it. Is all this driving you crazy? It drives me crazy because we can't find any agreement. We're not finding the same thing. An important component of the development of the DSM-3 was the use of the extensive field trials to evaluate. And this is what I was talking about. So they looked at field trials. They looked at several hundred patients. And they had different psychiatrists read their files and try to determine if they were getting the same thing. The most reliable diagnostic categories include mental retardation, or intellectual deficits now, of course. We don't refer to them as mental retardation, because this had to do with an IQ score. It was relatively simple. Mood disorders like depression, are they unhappy? There you go. Substance use disorders, are they using cocaine? Are they snorting cocaine or shooting up with crystal meth? A little bit, it's pretty easy to determine the tracks in their arm have to do with heroin. Okay, so those things were fairly easy. Schizophrenia, of course, this individual is not functional in society, so they're always going to be diagnosed with schizophrenia. But there's like 200 different diagnoses in there, and we're just talking about 5 that are really easy to read. So the rest of them are going to be a little bit less, a little bit difficult. Less reliable diagnoses include somatoform disorders, and the problem is that a lot of people can't even define somatoform disorders. Factitious disorders, that's a disorder that you kind of make it up in your own head. It's not a real problem, it's a thought of problem. Factitious, it's not real. Like, what am I thinking of? The hypochondria, where you think you're sick, but you're not really sick. That happened to me the other day. I told you during the break I thought I had appendicitis. I went and I had a bruise in my abdomen. The damn dog stepped on it. Did I say damn? Sorry. No. I had a factitious disorder. Okay. It wasn't real. I didn't have an appendicitis. I wanted one, but I didn't have one. And personality disorders, because personality disorders have to do with the way you project yourself to me. So if you talk to me, you may talk to me differently than you talk to somebody else. You may talk to a guy differently than you talk to a female. Does that make sense? Okay. So if I'm the one diagnosing you, I'm going to diagnose you with one thing, and a female clinician is going to diagnose you with something totally different. This is really kind of a serious problem, because you may have a problem when you talk to chicks, but you don't have a problem when you talk to guys. I used the word chick, I apologize. Okay, I shouldn't have used the word chick. It won't happen again. Does that make sense? Except for the chick part. Does that make sense? Okay, all right. So we're talking about personality problems. The results of reliability trials are not included with the publication of either the DSM-4 or the DSM-4-TR, nor have they been widely disseminated in the professional literature. So they did this with the DSM-3, and they discovered that they were getting pretty good kappa values. But then with the DSM-4 and the DSM-4-TR and the DSM-5, they haven't published anything. We don't know how accurate this stuff is. Reliabilities above .70 were found for all principal anxiety and mood diagnoses except for major depression. They just barely missed. I mean, it wasn't too bad, .68. So they weren't diagnosing depression very well. They also weren't diagnosing dysthymia. As you can see, it's .22. That's horrible. That's like a toss-up. So what is dysthymia? Dysthymia is the blues. It's low-grade depression, okay? So people aren't diagnosing this very well, the low-grade depression. Does that make sense? Okay, they're doing a really bad job on this issue. So.
All these disorders that you're talking about, it seems like some of them are rooted in the physical part of the body, like the word for retardation.
Oh, mental retardation.
Yeah, like those seem
Intellectual deficits.
yes, things that people are born
Disability.
with. Things that people are born with. And then there's things that where things happen to people for a prolonged time, and now they react. They learn a new way to cope or react.
Right.
So, how when you're diagnosing these things, does that make a difference on how you treat them, either chemically or?
Oh, sure, of course. If they seem like they're recovering on their own, then we probably wouldn't treat them at all. We'd probably just bring them in to counsel them and hope. And we would bring them in on several different days to find out if they were actually getting better. If they're not getting better, well, what will we do? Well, we'll throw some meds at them. We'll throw some Prozac at them.
How many disorders are there? Is there like a percentage of them that everybody can concur that they're untreatable, or like not untreatable, but
Difficult to treat.
like you can't, no matter what, you won't be able to fix the person.
Yeah, there are a select number of those, which is kind of sad if you think about it, because we're talking about antisocial personality disorder, which is almost impossible to treat. I mean, there's no medication for it. We have to convince the individual to stop acting like a jerk, to stop lying to people. You know, it's almost impossible to treat that. All we can do is identify them and keep an eye on them, and that's primarily all we can do.
Is pedophilia, is that a mental disorder under DSM-5?
Yes, it is. It's in the DSM-5. It is considered a mental disorder, but it's also one of the hardest to treat. We can condition people not to find children sexual objects. We can condition them to do that, but it's easy for them to lie to us, because well, all we know is what they said. You know, there is a way of testing them that we won't talk about. Well, maybe we will talk about that, but we won't talk about that right now. There's a way that you can figure out whether these people are actually getting excited when they look at pictures of children. We can determine how long they gaze at the picture, what they are looking at in the picture.
What have been some of the successful techniques for treating that disorder?
Successful ways of treating it? Well, we can condition them using different types of therapy, like shock therapy, punishing them for finding children attractive. The question is this a permanent fix? Normally what will happen with somebody with pedophilia, they get arrested, they get put in jail. In order for them to get out of jail, a psychologist has to evaluate them to determine if they are still attracted to children. And if they are, then potentially they are just leaving them in jail, if they're still attracted to children. But it all depends on the state. Some states you can't, I mean, if you give somebody a 10 to 20 years, you can't keep them over 20 years, unless they do something in prison. You can't keep them longer than that. You can't keep them longer than you have put them to jail for.
So in most cases, if they're still attracted to stay in there, in prison?
It all depends on the state, and it all depends on the psychologist. I worked with a guy that was his job in Ohio, was looking at these guys. Well, not just those guys. He was also looking at serial rapists and whatnot. And you know, it was tough. It was really tough because sometimes they look like they're fixed and they act like they're fixed, and you test them and you know, they know how to answer the questions correctly, so it looks like they're okay. But then he would interview them and he could tell what was going on. But in Ohio, if they put you in for 5 to 15, 15's as many as you can keep them. You have to let them out after that. And then, of course, they go on a list and whatnot. But how well does that work? Yes, sir.
I mentioned I read this book earlier about PTSD, and the only thing I could find was about rape. But I tried to see if there was any parallels. There were a lot of parallels, but it was just interesting to me to talk about rape, because I always just thought of rape as a man raping a woman, you know, somewhere down the street. I never really thought about it. I talked about child rape, I talked about prison rape, and for all the reasons people rape. It's not always homosexuality, or it's not always sexual. Some of it's power and politics and some of it. It was crazy. Then I talked too a little bit about the history of pedophilia in ancient cultures. So in some societies it was acceptable. Right. And then it's just interesting how we look at it here. And then you mentioned this in the last class. We look at some things as taboo here, but in other countries they're not. Right.
Yeah. Those of you who are in cultural psychology, there's a couple of groups, if you remember, in Africa,
Is it like in New Zealand?
Was it New Zealand? Yeah, it was in New Zealand. Yeah, it was in New Guinea. New Guinea. Yeah, there were two different tribes, and one you couldn't become a man unless you performed oral sex and on another guy, and you couldn't become a man. On the other tribe, you had to have anal sex with a guy in order to become a man. Which, you know, and this is perfectly acceptable for this group. And it was just the males, of course, becoming warriors. That's the only way they could become warriors, as odd as that seems. You know, and these societies do exist. They have their own culture. They have their own way of thinking, and can we say that that's wrong? I mean, if that's their culture.
How much of the DSM-5 is led by our laws and our culture here, Western culture?
It's printed in Washington, D.C., so it's the United States. The DSM-5, they read it in Europe, but they don't use it. But it's just an American text, reference book. Okay, so yeah, we're the only ones that use it as people in the United States. Canadians don't even use it. I know, you got a Canadian shirt on. It says Canada. I know, the Canadians don't even use it. What's wrong with those guys? I know, it's just an American thing, you know, and it's just a psychiatrist here. So, should we use it on the reservation? Are there some things about the DSM-5 that don't fit here? Well, I'm not exactly sure. We're going to go through it, and you can tell me if there's anything that doesn't fit, that we should discard for use in this culture. It makes perfect sense to me. If you guys want to just throw it out. Reliable classification is not necessarily a valid one. Diagnostic validity concerns whether the diagnosis measures what it claims to measure. So if we're looking for depression, does it really measure depression? We have a survey or a scale, does it really measure what we're talking about? If diagnoses show construct validity, then the separations between different categories should be discernible. Evidence should be available to support what belongs inside the category, convergent validity, as well as what does not, divergent validity, what doesn't fit. If a diagnosis has predictive validity, we should be able to say something about what to expect in terms of the outcome of or course of this problem. This is really interesting. This information was not in the textbook until they printed the DSM-5. And the reason it's in here now is because they're looking at the DSM-5 and there are some things that really upset people. And for that reason, they want people to start thinking about the DSM-5 critically. We need to think about this stuff critically. We are we have the right to reject what the DSM-5 says. We have the right to reject what was in the DSM-4 or the DSM-3. And certainly, how many of us still consider homosexuality as a mental illness? We certainly have the right to reject what was in the DSM-2, as far as that goes. Right? So we shouldn't stop being critical thinkers just because the DSM-5 has come out. This is not a perfect text. And we need to reject what is wrong, okay? So, and we all have the right to do that as psychologists. Psychology. I think we're learning psychology. I'm giving you the right to reject all this information if you want. If you don't believe in borderline personality disorder, then, you know, tell me about it. Or tell those guys about it. If you don't like the word mental retardation, don't read the DSM-4 TR, because it's in there all over the place. The DSM-5 has changed the nomenclature. Okay.
So is it good to study the DSM 1 to 5?
I'm sorry?
Is it good to study the 1 to 5?
No. No. Don't even look at those damn things. They're outdated. Don't worry about it. Historically, sure. If you want to know what happened in the past, or what we called things in the past, sure, go ahead and study the DSM-1 through the DSM-4 TR. But right now, this is where we are. What you need to be thinking about is the DSM-6 or the DSM-7, okay?
When do you think it'll come out?
Oh my God. Look how long it took the DSM-5 to come out. I mean, it took them 6 months for it to come out after they printed it. So, yeah, okay. So I'm giving you all the right to argue with this book, okay? The textbook, you can argue with the textbook all you want, but you can argue with the DSM-5, and you should. If you see something that they missed or something that really doesn't make any sense, reject it. Just reject it. And that's fine, because eventually they're going to have a DSM-6, and it's not going to be the same as a DSM-5. And things are changing. It's just like old soldiers. The problem with the generals of World War II was that they were still fighting the First World War.
The last war.
Exactly. The problem with Vietnam was we were still fighting Korea. The problem with Iraq and Afghanistan was that the generals had come up and through the ranks during the Vietnam War, and they were fighting the war in the jungle. Well, that's the dumbest thing in the world. That was the desert. You know, no trees, okay? Nothing green. I know. But we do this. We do this. And we think that all the information that I have, I got my PhD in 2012, all the information that I have is absolute. No, it's not. Everything's going to change. All the information that Sarah has, it's all going to change. Eventually it's going to change, and it's up to you guys to tell us that we're wrong, like using the word chick. Thank you. That won't happen again. Even though it just did, it's not going to happen again. Okay. There are general agreement the DSM-5 criteria, though far from perfect, makes valid distinctions between different symptom presentations. Those distinctions can also be meaningful in selecting treatment and projecting the course of many disorders. I got to take a drink. My mouth is so dry. I apologize. Okay. Validity presupposes reliability. If it's a valid diagnosis, then it should be a reliable diagnosis. So that's the assumption. The validity of any DSM-5 diagnostic category is limited to the reliability of that diagnosis. Okay. The DSM series is a product of the medical profession, and consequently, and this is one of the things, this is one of the things you need to think about. Remember that these guys are all doctors, and they've been all doctors all along. So these are all psychiatrists, and they use the medical model. So when they talk about a diagnosis, they're talking about a diagnosis that looks like it's the same way as it would be if it were a medical problem. Psychologists are not medical doctors. We do not look at things from a physical point of view. We look at it from a mental point of view. So the DSM-5 may potentially be completely inaccurate as far as psychologists are concerned. Diagnoses are not disease. These are not diseases. These are mental aberrations.
When did psychologists start getting FDA numbers and allowed to prescribe medication?
Oh, good question. Wow. 70s, 80s, and they could only prescribe select medications such as Valium or Librium. Anti-anxiety, mostly anti-anxiety. The antidepressants were relatively toxic.
Like trazodone, stuff like that?
Trazodone, that was after Vietnam. Yeah, that's for PTSD. Yeah, it was after Vietnam. So that's the 1980s. It all depends on the state. In some states, social workers can prescribe medications. Yeah, I know. It all depends on the state. The more people you have in the state, the more likely that only a psychiatrist can prescribe medications. New York, for example, California, Arizona. I'm not exactly sure what's going on here. I've only been here for 2 years. I haven't figured it out yet. So, yeah.
I know,
It all depends on the state, and it all depends on.
I know on reservations, like nurse practitioners can
Yeah.
prescribe medicine.
Right.
I
And
don't
then
know
the
if
military.
that's, I don't know if that's true in the state of Arizona, but on the reservation it is.
I don't know. I know a doctor.
Is cannabis one of the treatment for depression? Medical marijuana?
For depression?
Mhm.
Not that I'm aware of. Not. I don't think so.
I was just wondering.
Okay. It's mostly pain control.
They started using ketamine recently, though, right?
Yes. Yeah. And ketamine. Of course you. Ketamine was what we used as a anesthetic. Not an anesthetic. How we used to knock people out in Vietnam was with ketamine. As strange as that may seem, ketamine has really interesting side effects. Anxiety, I guess, is one of them. But here we are, we're knocking all these wounded soldiers out with ketamine so that we can do surgery on them. Of course, they're waking up and they're hallucinating and all kinds of interesting things are happening. Sorry. I know, ketamine. Yeah, but ketamine, yeah, it's actually a hope. Yeah, we used to knock people out with it. Not an anesthetic. What's the word I'm thinking of? Anesthetist. Anesthesiologist. So it's an anesthetic. Okay. Sorry. It's been a long day. At present, there are no medical or biological tests that can confirm or verify the vast proportion of specific DSM-5 diagnoses. One of the interesting things about medicine is that as a laboratory technician, I could run a test on somebody to find out if they have liver disease, to find out how their kidneys were doing, but we can't do that with any of the mental illnesses. We can't give you a lab test. We can't draw your blood. We can't look at your urine to figure out what's going on with you. We can determine if you've got something in your system, like marijuana or cocaine, but a psychotropic, but we can't determine if you've got depression by looking at your blood. We can't determine if you're schizophrenic by looking at your blood. And that's what doctors want. Yes, sir.
How do they then determine like someone who's having a problem with reuptake?
Okay.
You know,
So you're talking about serotonin?
Yeah.
Okay. Yeah, we can draw your blood and tell how much serotonin you have in your system. But all we can tell is how much you have circulating in your blood. We can't determine how much is up in your brain. Because when we're talking about serotonin, we're talking about the amount that's in the synaptic cleft of the neuron. And that's what makes you happy or not happy. But all we can tell is whether you've got, how much you have in your circulatory system.
So they do base that on a relative scale to other people?
Well, we can't do that. Once upon a time, we can determine how much marijuana you smoke, but we don't know how much marijuana causes you to be act crazy, or to be to drive erratically. But we know how much alcohol makes you drive poorly, but we don't know how much marijuana in your system makes you drive erratically. I know, isn't this strange? So the problem is if we arrest somebody for driving while intoxicated, if they've been smoking pot, the problem is that we don't know how much pot causes you to act erratically or to drive poorly. But we know, as far as alcohol is concerned, we can measure, but we can't do that with marijuana. And the other problem is, of course, if you're an alcoholic, then you can drive without any problems whatsoever with a relatively high alcohol level because your body is used to it.
Yeah, I always thought it was odd that they based the DUI prosecution on BAH, but
Sure.
or BAC, but then
Right.
they don't ever take into account weight or sex,
No.
or
Nope.
anything like that.
And potentially you could fight that in court, but all the states have determined that it's 0.8. Some of the countries it's 0.6. So they've all determined that this is the level that's after this level you start to drive poorly. That's what they've determined.
Isn't it the same with marijuana when you smoke it? Depends on how long you smoke. And your body can get used to it.
Yeah. Oh man, it's really strange because if you've been smoking marijuana for a really long time, you've got a lot of marijuana in your system, and you can smoke a little bit and get just stoned out of your gourd. Yeah, I know, it's really kind of bizarre. It's got reverse tolerance.
Because that's like how ibuprofen works, right? It takes 2 weeks to build up into your system.
Ibuprofen? Okay. Yeah, I guess.
So you have to take it for a prolonged period of time for it to build up in your system.
Well, ibuprofen blocks substance P. So as long as it's blocking substance P, I guess we're okay. What time is it? Well, Johnny's putting his jacket on. So why don't we stop?
Yeah,
It must-
4:20, man. You're talking
Okay, yeah, okay.